everyone with an interest in NASH, or more broadly, fatty liver disease? Surf's Up, Season 3, Episode 53 of Surfing the NASH Tsunami. Our real-time coverage of the first 3 days of the Liver Meeting 2022 from AASLD starts now.
Today, on Surfing the NASH Tsunami.
We are becoming increasingly spoiled for choice. It's not clear that we know yet what the answer is, capital T, capital A, which frustrates commercial folks, but that there are lots of directions where you can find pieces of the answer.
The biology within the liver is capable of reversion. The question is, how do we do that without having to commit to surgical, more aggressive approaches?
We have to start to consider if we really want to expose patients to a painful, invasive procedure. Doesn't carry a high mortality risk, but patients have succumbed to liver biopsy, or at least in the follow-up. Is this still the right test?
For every 1 cell of human cells, there's 10 cells of microbes. So there's a lot to be learned here in implications in health and disease, and all the steps to stage.
But there's going to be a lot of singles and not many home runs in NASH, I think. We're learning that the hard way. We need to recondition ourselves to expect small steps and not a blockbuster. I hope I'm wrong, but
you might be right.
This week, roughly 7,000 hepatologists and hepatology stakeholders have gathered in Washington, D.C. for the Liver Meeting 2022, the first in-person AASLD with on-site attendees in 3 years. Please join hepatology researcher and key opinion leader Professor Jörn Schattenberg, pricing and forecasting guru Roger Green, and today's guests, hepatology researcher and key opinion leader Professor Scott Friedman and entrepreneur and age diagnostics CEO Rachel Zayas, as they review some of the highlights and key issues of the first 3 days of this year's conference, on this special episode of Surfing the NASH Tsunami.
For those of us who recall our NASH Tech coverage earlier in the year, we have settled permanently on the idea that the right way to do major conferences is at 7 o'clock in the morning. So right now it's 7 o'clock on Monday morning, and we have with us a hearty band of people who've actually made it up in one piece to do this. Jörn, how are you this morning?
Good, thank you. I'm grabbing my first coffee. It was a busy meeting until here. Very happy to be joining you guys from my hotel room. It doesn't seem to be quite as nice as Rachel's and yours, Roger, but I'm hanging in here.
Well, Scott and I are in the same hotel, and Rachel, where are you today?
I am in my cozy apartment here in North Capitol, so I did not have to travel far to get to this meeting. I have been walking to the convention center every day.
And Jörn, if all of our hotel rooms could look like our cozy apartments, life would really be good, wouldn't it?
Right.
And then we have Scott Friedman with us. Scott, how are you today?
I'm great. How are you, Roger?
I'm doing fine. Scott and I, for those, you can't see this because this is audio, but Scott and I have identical decor because we are 4 floors apart in the same hotel, which was Jörn's point of reference. We were supposed to have Chris Cowdley with us today. Unfortunately, he came down with the flu. We were supposed to have Naeem Al-Khoury with us today. Unfortunately, he came down with a logistical challenge. So the 4 of us are just going to have fill in like we're 6 people, which I think should be a reasonable thing to do. Just to start, so I'm not going to use whatever script I gave you guys. We're just going to kind of wing and see what we get. Just to start, I'd like each of you to take a minute and just generally share your impressions of this meeting so far, general feel of the place, and then anything in particular you've liked or think is noteworthy that you didn't expect. Brave one, go first.
Well, I'll jump in. It's great to be back. It's a great feeling to see people. It's a reminder of all the things you lose when you have a strictly virtual meeting. Of course, that relates mostly to the personal interactions that you miss when you're on Zoom. For me, it's been the one thing that I really didn't remember and that I was happy to renew is the sense of excitement among my trainees who are coming to the meeting for the first time. I remember it well. It was 1983. That's quite a ways back. I haven't missed a meeting since then. But I remember as I looked at them how thrilling it is to realize they're not the only people, apart from my lab, who are interested in liver disease, that there are literally thousands of people who've converged on the convention center to talk about one organ. So sort of seeing the world through their eyes renewed for me the excitement of working in this business. It was very satisfying.
That's fantastic, Scott. Rachel, I saw you nodding enthusiastically. Why don't you go next?
Yeah, it's really nice to be back in person. AASLD did a fantastic job transitioning to the online modalities during COVID, but just the energy in these rooms, it's infectious. conference. And one of my favorite parts of these conferences are the dialogues and the panel discussions. I think that they're insightful, they're thought-provoking, and it's just really great to see so many people so excited about liver disease in the same room. And, I have a few colleagues in town here, and they've never been to AASLD, so they're taking it in, and I appreciate that.
And for the record, I was told yesterday at the past president's reception that there are 7,000 attendees, which is actually above the industry standard post-COVID, which was about 65% of the max. So we would pull in around 10,000 people in the past. So having 7,000 is a pleasant surprise. It doesn't feel empty or cavernous. It seems like there's a lot of people around. That helps add to the energy. There are very, very few Asians and not a lot of Europeans either. Jörn may want to speak to that, but it is noticeable. It doesn't feel as multinational, even though I know there's 55 some odd countries represented here, and we're clearly not capturing the worldwide attendance that we would like. And there's lots of reasons, of course, for that.
Jörn, in talking about the meeting and your day so far, Scott's invited you to capture that.
I was going to say something different, but I'd like to follow up on Scott's comment and say that it's true. I'm actually here with a fellow of mine and postdoc from the lab, and they're both very excited. And, joined there by a student who did a rotation at Mayo this last summer, and she got so excited about liver disease that we looked at funds to fly her in. So she's staying here, enjoying her first liver meeting. And I think this is really a way to get people hooked to the field because it's so much vibes and positive energies. Thinking back of the days, I had my first liver meeting not quite as far back as Scott goes. I always enjoyed the interaction, seeing the people in the poster lines up and discussing the science with them. So that's the magic, and it's back, and that's great. On the other hand, those international travel for Europeans are important, are expensive, and taking out that going back and forth, you have 6 hours time difference. I think it's always been tough for schedules, funding required, and we'll see how it goes. I mean, with the option of virtual, I think the European attendance will come in at a little lower, steady level.
No doubt. I actually heard a horror story also of several of the faculty who came in were waiting 3 hours to get through customs at Dulles, and that's just an embarrassment. It's terrible. Of course, that has less to do with the meeting and more to do with U.S. Customs and Border Patrol, but painful to hear that story. I certainly
not good.
Pretty ornery if I arrived, waited 3 hours.
It's been pretty bad, so hopefully there's less barriers to entry going forward.
That might be about Dulles, though, to some degree, because the last 3 times I've come back in this year have all been through Newark, and they've all been pretty easy. One was 15 minutes. The other 2 were essentially painless. Since I remember you and I were supposed to speak right after you flew in, and you called me an hour and a half after we scheduled, and you were still in customs. So how long were you there for that night?
That was an hour 15, and I thought it went pretty well. But in general, you get to the airport anxious going down that escalator, looking at that line, and they queue up, and they have like 40 going back and forth, packed people. It's crazy. They don't have automated entry machines here. So even if you're not a global entry person, it's difficult for you people to get that. You could have automated machines that would expedite the process. I think there's room for improvement. Let's put it that way.
Yeah. Coming back from Dublin, they had automated machines, but the photos on them were so bad that I wind up having to not be able to get my picture taken and then having to stand in line. All right, people don't need to hear about all our customs horror stories. We're fortunate to actually get to travel internationally to go to these things, and I think I'll probably leave it at that. So that's impressions in general. Anything you heard, before we start on specific presentations, anything you heard yesterday that particularly surprised you or you found particularly striking?
Touching back on the issue you had previously, and not even sure it's on tape, Roger, is that, we have the ongoing consensus meeting, which keeps the field pretty busy. There was a big consensus meeting yesterday, and Professor Mary Ranilla actually gave a presentation on the AASLD guidelines, new guidelines presented by her yesterday. So there's a lot of thinking about the framework of NAFLD. What's the way moving forward? Do we change the definition of the disease? I think the overarching team is no, we don't want to change the definition, but there might be some adjustments to the actual wording we give to that well-defined condition, and she highlighted that also in the guidelines. And one aspect that came out in the guidelines session actually that I found interesting, it seems to have an ALT cutoff of 30 in there that might consider a trigger referral, which will probably be pretty difficult in clinical practice, but we'll see how that reads out in everyday life.
Why don't we just kick into events? Whoever wants to go first, pick a paper or a presentation that you found particularly striking or important yesterday, and take a few minutes and run us through it.
I'll begin. So there was a poster presentation that I found quite compelling. It's called Diabetic Persons with HIV and Hepatic Steatosis Have Reduced Intestinal Microbial Diversity. It was by Curtis Gabriel out of Vanderbilt University. Liver disease, of course, is the leading cause of mortality in between patients with HIV and they suffer a disproportionate burden of NAFLD. Dysbiosis is implicated in the pathogenesis in HIV negative person, but the mechanisms have been underexplored in patients with HIV and NAFLD. So their aim was to assess the association between intestinal microbiome in patients with HIV and NAFLD. So they looked at a retrospective, they looked at patients on antiviral therapy between 2017 and 2020. Patients with diabetes were included because of the high prevalence of NAFLD in this population. Patients underwent CT scan and liver density to measure fat content, and then stool samples were collected and sequenced using 16S rRNA sequencing. This is a tool that can be used for classification and quantification of microbes with complex mixtures, and they can differentiate between similar species. In the study, they had 8 patients without steatosis, so patients with HIV and diabetes without steatosis, and 9 patients with HIV, diabetes, and steatosis. So what they found was that there was abundance and increase in Bacteroidota, which is a type of gram-negative bacteria that can colonize the GI tract, and a decrease in spermicide species in the patients with HIV NAFLD. What's really interesting about this is when I look these up, it's actually the opposite in early NAFLD patients. That was compelling to me, and I wonder if the microbiome environment changes over time. So there's an increase in the ratio at one point. It sets the stage for an environment, and then a decrease. But what their key takeaways were from this study is that they can link intestinal dysbiosis to hepatic steatosis in patients with HIV, and future studies should continue to explore this. You know, a lot of studies implicate both diagnosis as well as treatment, but I think just asking the questions of what does the normal microbiome look like initially, and how does this change over time? So I found this a compelling study.
I agree with Rachel in terms of the importance of the microbiome. This is one of the variables that we still can't fully get our arms around. And to be clear, it's not just the microbiome bacteria, but it's the virome, it's the fungome, God knows what other organisms we're overlooking. But putting this all together into a coherent story is not trivial, and I think it's really one of the challenges for today.
The aspects I'm thinking of, Rachel, is inflammation triggered through the microbiome or the composition, feeding into insulin sensitivity or resistance, and some changed, lipid peroxidation mechanisms that could contribute to that.
Yeah, it begs the question that we really have a limited understanding of these species and these environments that are really orchestrating health and longevity. For every 1 cell of human cells, there's 10 cells of microbes. So there's a lot to be learned here in implications in health and disease and how this sets the stage. I would be really interested to see some long-term studies with these patients to determine which bacteria is protective, which is associated with decreased risk of survival. I think that's a question that is yet to be answered, but it would have a lot of implications. So that's something that I would be interested in. So I'll have to follow up on the study in the coming months.
I think the broader implication, which Rachel's comments hint at, is how much of this disease is actually a gut microbiome disease, meaning that have we changed the nature of our intestinal flora over the course of 20 or 30 or more years, in part because we eat foods that have antibiotics indirectly in them, because we take antibiotics indiscriminately for every headache or stuffed nose. And there's a school of thought that suggests that we have effectively shifted our microbiota towards one that is more fat and energy retaining through these society-wide changes in our food and in our use of antibiotics. And until we understand that, we're really not going to be able to slow the progression of or the increasing prevalence of the disease. That's a simplistic perspective, I understand. But, there are a lot of animal studies that support the importance of the microbiome in either driving or attenuating fatty liver disease.
Well, look, the phenomenon you just described, first of all, doesn't pertain only to fatty liver disease. We talk about decreases in sperm counts, changes in the age at which females, I'm not going to say girls, I'm not going to say women, because I'm not going to put age on things, but, come into puberty. All that stuff is, I think, back to antibiotics and different kinds of hormones that go into food and the environment and everything else. There's a meta message, which is that we have a lot more control over ourselves and our own lives than we necessarily give ourselves credit for. I have a cousin who underwent bariatric surgery, at which point she's gotten her weight down to a normal zone. But I watch how she feeds her kid, and I tried to explain to her at one point, Rachel, your statement about the what's 10 microbiome for every gene. She said, well, no, if my kid has this problem, it's going to be genetics. I said, well, no, I don't think it's quite that simple. And then explained and got stark denial. That's not a surprise. But I think we would do well as a society to start educating ourselves that every day we can take more control of how this stuff plays out. Scott, that's not going to overcome the global issue you're talking about. Well, I guess if you make a point to eat foods that don't have antibiotics in them, and are labeled in certain ways, it's better.
It's a good point, Roger. I don't know what are the conditions that define something as non-GMO, genetically modified. Does that mean that there's a guarantee that nowhere along the development of that product there was exposure to antibiotics? What about the grain that's being eaten by the farm animals that ultimately become our food? Is that whole chain free of antibiotics in order to be GMO? I don't know how these are defined.
Actually, when I was a grad student, I was teaching a really compelling class called Chemistry of Cooking, and I had my students look up the labels from the USDA to determine what is considered organic and non-organic. And organic often indicates no GMOs, but organic does not constitute no pesticides, herbicides, etc. So it's false labeling, it's confusing, and the everyday consumer does not really know where their food sources are coming and how they're being treated. So I almost think that we have little control over what we consume and how much. And Scott, as you were just alluding to, there's bioaccumulation in this from every step in the process. So I don't know how much control any of us have individually over this, which is problematic.
One would infer then that if we have any control over it at all, to get to a place where we're going to stop, because I don't want to go any further on this line, it involves our activities as public citizens and voters and advocates for different things. So fundamentally, if you can't change it for yourself, then you got to figure out how to change it for the world. That's going to be a complicated set of questions. I think that's kind of the path I hear the two of you going down.
Well, I'm down about as far as my knowledge will take me, probably beyond that. I'm over my skis right now, so I'll pull back.
Scott, I just landed on my nose, so I mean, I'm right there with you. Rachel, thanks. That was a fantastic way to start this conversation, and I think it's interesting. Go to a liver meeting and wind up talking about public policy that has nothing per se to do with the liver. It's all interconnected. I think that's great. Scott, Jörn, why don't one of you two go next?
So, I should say when I come to these or any meeting, I try to say to myself, well, what have I actually learned? What's different? And I distill it to more broad themes. And to me, the theme of the meeting is the devil's in the details. What do I mean by that? As a translational investigator who also relies a lot on, animal models and cell culture models, I've always tried to be as reductionist as possible to try to explain phenomena with a simpler pathway, with a simple paradigm. And unfortunately, that impulse is being completely squashed by the reality of what NASH and NAFLD are. And so I walk away from this being somewhat sobered by the fact that there's details in the cells that comprise the NAFLD or NASH liver, the probably different pathologies, the different genetic backgrounds, the different microbiota, and of course the differences in clinical management and diagnostics as well as treatments. This complexity is really a new challenge conceptually. It's not a single disease with a single pathogenic kind of vulnerability that everybody can treat and solve. One of the problems with the field is that everybody naturally approached the disease as, this is going to be a simple problem. We'll just press the right button and we'll solve the problem. Certainly in the investor community, there's been a lot of exhaustion because they want quick wins, and this one seems to be a longer-term challenge. I have absolutely no doubt that the disease will yield to effective therapies, incrementally but effectively. But still, I've been forced kicking and screaming to appreciate that this is a very complex disease and one that we will continue to sort of advance in small but meaningful steps. Well, that's been, for me, that I can give you examples of that. Steve Harrison did a really nice job of presenting an approach of diagnosis with a particular trial of a drug that inhibits the enzyme fatty acid synthase, which, if you block it, will prevent fat accumulation in the liver. And with all of the different tests, there were still no guarantee, for example, that an improvement in liver fat translates into an improvement in histology in all patients, that the same combination of tests in different people will yield the same predictive value. He did come away with, a couple of tests that seemed to be more informative when you combine them. I think it was AST and liver fat. On the other hand, he showed that one of the liver fat measures that is used increasingly, called the CAP score, turned out to have no correlation with the amount of fat, and therefore is just a binary readout of does the patient's liver have fat or not. This became a very nuanced nuanced discussion that, quite frankly, at the end, I wasn't sure we'd made any progress, except to understand that just measuring fat in the liver is never going to be enough for every patient. Some patients, probably the way you reduce the fat is going to be clinically meaningful, and others not. And it always comes back to the simple fact that most patients in the world who have fat in their liver do not develop NASH. So clearly, fat alone is not the problem.
Yeah, let me jump in, because it sounds a bell with me, and you're talking about natural history, but it might even be that not even any drug has to, have an effect on all these attributes in the disease. And you and I, Scott, discussed this previously, where you could develop a drug where fat content is not changed, but it has an influential benefit on inflammation and cell injury, and that way you still get a net benefit. But if you look at it and the patient has fatty liver and fatty liver doesn't go away, the question is, will he benefit at all? So then it depends on the test, it depends on the mechanism, and maybe the genetic background. We're learning in that sound resonance with me here, what Scott is saying. We're learning it's a complex disease. Some subtypes, we're making progress, and you can't just look from the very top and say the fat is the bad thing. You got to really break it down and understand what's happening.
The way that you both just framed that makes me want to
Scream,
yeah. Certainly, it's complex and it's nuanced, and it's taking me a couple years to start to get a handle on everything involved in NASH and fibrosis. But what you both just said, in a way, is not what is driving the disease, but also what is protecting those patients who do not go on to develop adverse outcomes with NASH. And that is a question that would, of course, take a lot of resources and a lot of time. But I think it's an important question in the field. What are the protective mechanisms that are occurring in these patients? Is it epigenetics?
Yeah, well, it's a great point, Rachel, and that path has been pursued in other diseases. So I can't think of an exact example, but there are clearly some diseases where there is some genetic mutation or variant that is associated with disease, and yet people go a whole lifetime and never get the disease, even though they have the genetic risk. And that has driven geneticists to look at what are the protective factors. So I think that's a very interesting and sensible way to frame it, particularly since the vast majority of people with fat in the liver are protected from NASH. So they clearly have something that the others lack. There is one example in NASH that it may be instructive, which is the polymorphism in the gene HSD17B13 that was discovered probably now 4 or 5 years ago at Regeneron. And it turns out that the gene encodes for an enzyme, the substrate of which and the product of which we don't know yet. Yet, if the enzyme is inactive because there is a gene variant that turns off the translation and they don't make the gene into protein, those patients generally have normal or lower AST and ALT. And that's true in alcohol, it's true in non-alcoholic liver disease, it actually is true in other liver diseases like Hep C as well. So all of that suggests that here's a built-in protective factor, which is a variant in a gene that prevents that gene from being active and therefore from the enzyme doing its job. Now, the critical question is, what is that enzyme generating? Because therein lies perhaps one of the secrets of why fat converts into an inflammatory disease. And so people are scrambling to first understand the biochemistry of that enzyme, what it normally makes, and what you're preventing the generation of with the variant. But from a more practical level, it's already led to at least 3 or 4 programs in the commercial world to simply antagonize the protein, either with an siRNA or with a small molecule, in those patients who otherwise would express the active gene and make the injurious species from the enzyme, whatever that may be. That's a path that's been well trod by the example of PCSK9, which is an accessory receptor for cholesterol, and I'm out of my depth here on the lipid biology. But it was realized that patients who had a variant of inactive PCSK9 were completely protected from coronary artery disease. So the smart scientists and companies who recognize this said, I have an easy solution. For those who have normal PCSK9, let's develop an inhibitor. Who knows what it does? And of course, now they do know. And in fact, inhibitors of PCSK9, either through small molecules or siRNAs, have become a mainstay for people with extremely high cholesterol where statins don't do the job. So we're encroaching on a better understanding and a better nuance, and it flies in the face of simple models that apply to every patient and every instance of fatty liver disease.
So, Scott, one of the things I find really interesting in that comment is the fork in the road between why does that happen and what do we do about it, right? And the idea that, in fact, you might not need to know why something happens in order to know what to do next, which isn't historically how we think about this stuff, right? Knowledge yields more knowledge, but sometimes you can chase the why down a rabbit hole where you could just more quickly and more easily get to the, okay, is there anything we can do about this? Which I've got some familiarity with the commercial issues around PCSK9 and how a lot of the thinking around that developed commercially, not scientifically, but I know that that's a case where investors would ask questions like, well, why is it going to work that way? And the answer is going to be, well, we don't know. We just know that it will, at least in the early days. And that was enough.
Yeah, it's still enough. I mean, PCSK9 inhibitors are unbelievably potent. Having kept up with the biology, I know there's a lot known now about why blocking it prevents hypercholesterolemia, but they're very potent.
So, but if you carry that into fatty liver, right, one of the thoughts is if we can figure out how to fix a couple of these things without solving the problem, you might get to a better solution once you know what you just fixed, which is, I think, the PCSK9 story. Fix it first, solve it later. So, Jörn, your turn.
I mentioned the complexity of the disease and the subtypes and so on, but Scott, you are right. I mean, if we enter that lane and show improvement, it can reverse, maybe, in reversion, we can solve the question, we cured these guys, let's look from the back end and see what helped them. So it might not be as difficult or mind-blowing, and maybe we can't understand everything from the beginning, but we will once we have a treatment on Scott's sides that this is feasible, possible, and we'll be there soon.
Yeah, and of course, the thing let's not forget, this is a disease that does yield to therapy. It happens to be mostly bariatric surgery at this point, but the data couldn't be more compelling at how you save lives and reduce comorbidities when patients undergo bariatric surgery, as long as they keep the weight off. And so the biology within the liver is capable of reversion. The question is, how do we do that without having to commit to, surgical or more aggressive approaches?
Yeah, and as we've just said, I think the trick might wind up being to reverse engineer that, although that's easy for me to say. I haven't taken a natural science course since high school biology, so I can approach this not at 30,000 feet, but at 30,000 miles, look down on Earth and say, well, there's a solution. Then you guys have to figure out what the heck it means. But I think that these are all excellent points. Jörn, you want to talk about a presentation or paper?
Yeah, so the paper I want to discuss is entitled The Effect of a Dual Receptor Glucagon-like Peptide 1 and Glucagon Agonist Cotadutide on Serum Metabolomes in Biopsy-Proven Non-Cirrhotic NASH Patients. So that was presented in Parallel 12 yesterday till 3:30 session Sunday afternoon. As most of the listeners might be aware, cotadutide is a dual GLP-1 glucagon agonist. The nice thing of that MOA is it adds the backbone of weight loss, which is highly effective in treating obesity and diabetes, but it also has a component that actually has a liver-directed effect, the glucagon agonism. And those play together well. Cotadutide is explored in obesity and also NASH, and data that's presented here is a breakdown of the Proximo study, which is a 19-week multi-center phase 2 trial, 74 patients biopsy-confirmed NASH, and the authors present metabolomics. Metabolomics were done at baseline in week 19, and they used the OWL metabolomics platform to different readouts. And I think it's one nice way to address the aspect of we're tied to histology for conditional approval of a drug. We're tied to hard outcomes for definite approval of a drug in NASH at this time, but there are so many ways to understand what the drug might be doing, demonstrate benefits in terms of secondary outcomes and pathophysiological plausibility. And as such, I think these programs that augment a clinical trial program beyond the decision, we're going to continue this or not based on the primary readout, this is very interesting, and metabolomics are, of course, very powerful. I'm sure Rachel and Scott have some thoughts to that, but let me just detail the results quickly. So they have a lot of metabolic features they looked at and then dissect metabolites that are associated with NASH. Sphingolipids read out here, and cotadutide was applied in 2 doses. In the high dose group, there were significantly more suppressed over placebo, and branched chain amino acids as well as leucine were aspects they were looking at. So using very powerful techniques like metabolomics, you can actually detect serum metabolomic profiles that do correlate with drug response. Now, that doesn't have necessarily to say anything for the primary endpoint and the outcome, but it shows us how the drugs, even beyond the primary liver endpoint, read out and might be beneficial for the patient. And as such, I do encourage you, if you're in drug development, to add in these programs and help the field to understand what's going on.
It's very interesting and a lovely description. I guess the other complexity we haven't talked about yet is how these drugs affect other organs that contribute to the metabolic syndrome. So we're obviously very liver-centric, but we all recognize this is a systemic disease. So that means disordered biology in muscle, in adipose, heart, kidneys. As I think about these combination therapies, I'm also thinking about how the benefit may accrue from effects outside the liver, particularly adipose and muscle. So those are things to think about. Of course, when you're a hammer, the whole world's a nail. So we worry about the liver, but the endocrinologists worry about the muscle and the adipose and, of course, the pancreas, which, let's not forget, is the master of glucose management.
Yeah, I was going to add to that from a pessimistic point of view. If we're developing new therapeutics, if we're utilizing small interference RNA, if we are silencing a gene in the liver, it might be critical to have the expression of that gene in another organ in the body. So it's something important from that perspective to ensure that there's not off-target effects. But this comment can go both ways. Of course, off-target effects are critical, but then on the other end of that spectrum is what is going on in the other organs in the body. And I haven't seen that too often, but I think that is a critical question going forward, especially with gene editing technologies as well as the drugs in development.
Well, that's a great point. I think one of the themes that's sort of almost below the radar here is that gene therapy has arrived for real. And it turns out that's a boon not just to patients, but also to liver specialists, because if you don't do very much to tweak a delivery vehicle to get genes into the body, they almost always go to the liver. So, there are some real success stories here for monogenic diseases like alpha-1 antitrypsin. There was a very exciting paper that suggests that can be managed with an siRNA, but more even to the point is one of the porphyrias, as well as blocking on the other monogenic disease that is amenable to gene therapy. And, there was a catastrophic situation probably over 10 or 15 years ago of a young man who died in a gene therapy human trial because the viral carrier was eliciting a massive inflammation, and the young man died. And that both stalled and sobered the field for a very long time. But slowly but surely, the field has come back in a much more nuanced and, I would say, clever way. One of the big stories to me actually comes out of the COVID-19 pandemic and the development of lipid nanoparticle carriers. So if you think about it, the mRNA vaccines are gene therapy. Of course, the companies that make them don't want to remind us of that because that elicits a lot of anxiety on the part of mostly, I guess, patients and maybe regulators. But the fact is, those lipid nanoparticles now have been very finely tuned. There's a tremendous amount of biochemistry and pharmacology that's gone into refining these so they can get to the tissue you want them to get to. They can deliver their payload. And in the case of the COVID-19 vaccine, they can also encode for proteins that will elicit an immune response that protects us. So that's really been an under-the-radar success story now after years of trying and, of course, caution. Those gene therapies have arrived for some liver disease. And, of course, to circle back to the HST17B13 story that we brought up before, if we want to neutralize that, there's one company that's now got an siRNA delivered to knock down that gene so that patients who have the risk polymorphism, their expression is reduced to mimic those who are naturally protected because they don't express the protein. So another off-the-main road success story of gene therapy, which I think will slowly but surely creep into management of more complex and prevalent diseases like fatty liver disease and NASH.
So I'm intrigued by your use of the verb creep in, right? We've talked about 4 or 5 different ways this morning that knowledge can be enhanced. And it strikes me all of those fit into the category of creep in, right? Fix it and figure it all the way from the one extreme, fix it and then figure out what you did, to what you described, Scott, which is very, very fine tuning at what look like the edges, but might actually get you to the core pretty quickly. It's a funny thing. I felt a little bit in this meeting that like we are becoming increasingly spoiled for choice. It's not clear that we know yet what the answer is, capital T, capital A, which frustrates commercial folks, but that there are lots of directions where you can find pieces of the answer. So far, in just probably 35 or 36 minutes of tape, which will be 28 minutes by the time anybody hears this, we've done a pretty good job of elucidating 5 or 6 different ways of getting there. Thoughts, comments?
Yeah, patients, providers, and certainly investors in pharma and biotech companies want a big story, a big win, a front page headline, disease cured, and that's certainly great when it happens, but there's going to be a lot of singles and not many home runs in NASH, I think, and we're learning that the hard way. We need to recondition condition ourselves to expect small steps and not a blockbuster. I hope I'm wrong, but
you might be right. But let me go back to the metaphor of NASH and cancer that I talk about from time to time, because, right, if you remember, back in 1969, Nixon declared there was going to be a cure for cancer, capital C for cure, capital C for cancer, right? And what might look like a single in NASH might look like a home run in cancer, because you define one particular type and then you knock mortality way down and you declare that a home run. In NASH, because it's not mortal in the same sense, with the same kind of direct effect, it's going to wind up looking like a single. But it took 50 years to start to come back to things like microsatellite stability and some of the other things that appear to run across cancer lines, after we had to break everything down into very small component parts, and then we could take a look and say, okay, what are the common themes here? My suspicion is that NASH will wind up looking like that, because dynamically, to me at least, it feels like the same thing. Every time you think you have a big answer, it turns out it's just not quite that, but the small pieces work better.
Or for a subset of patients, it's not one cure fits all.
Yeah, which means, going back to your previous comment, that liver scientists will have a lot of work to do for a long time, which is a good thing. Everybody come to hepatology. All right, so I went to session 12 yesterday wanting to see 4 papers, and the one that struck me the most was one of the 2 that, from the description, where the description didn't do it justice, which was Emmerich Shaw's rather compelling takedown of biopsy from a direction I've never seen anybody take biopsy down before. That could be because I'm new here, but we talk a lot about the statistics of different sample sizes, right? And if you think about all the conversations about FIB4, it's all about what does NPV mean in a population that's 20/80 versus a population that's 50/50. I thought Dr. Shaw's paper yesterday was a pretty compelling look at the idea that by its nature, if you look for a 2-point discrete distribution to determine success, that you will systematically underplay the value of the therapy that's improving things, because the statistics are going to force all the error in the same direction. And what I thought was neat about it, you guys who know this field a lot better could have a completely different view, and I could be way out to lunch, in which case we'll play that and I will confess to naivete. But the idea that goes, by definition, if you improve response, all the systematic error is going to overplay the value of placebo and underplay the value of response. Therefore, it becomes one more piece of the argument or the question that goes, why we shouldn't be looking at ballooning, for example, as a yes or no, as compared to a distribution of space involved, because the statistics have to become the sophistication of what you can measure, and the error in the statistics have to align. And I did not expect that paper from what I could see in the abstract, and I don't have the abstract up in front of me right now because I've got to have the screen in front of me. I will post it when we post the article. But I thought it was a really compelling look at why it virtually has to be that you're going to understate the value of efficacy in a bimodal distribution, which makes biopsy a problem.
So is this the emperor has no clothes?
Yes.
Very provocative. And, I'll tag along and make a sub-point, which is it is increasingly irrational to rely solely on the subjective assessment of a liver biopsy by a pathologist, with all due respect to pathologists. It is just nonsensical. Now, the FDA is not averse to embracing digital pathologies, but they want to see the data, and that's only fair. And that data is coming along. There's a paper that came out earlier and 2 abstracts that were presented here with different drugs that suggest that if you look at drugs that purportedly have no effect when assessed by a pathologist, and you take an objective, quantifiable assessment of the amount of fibrosis, the amount of inflammation, the subtle features that can be quantified objectively, that in fact there was a therapeutic benefit. There was one paper from Nikolai Naumov that just published in Hepatology, I think, in the last month or 2, looking at the tropifexor data, which was an FXR agonist that purportedly failed, but yet there was clear evidence that there was improvement. We have got to get these digital pathologies into the mainstream as endpoints in clinical trials, and not a moment too soon, because we're probably, in addition to, for the reasons you stated, Roger, we're probably discarding drugs that clearly have a benefit, but that may take more time to reveal.
Okay, so the thing I'm probably most fascinated to see if everything today is going to be Arun Sanyal's redefinition of the regenerate data in late breaker, because I have a sense that we might wind up seeing something like what you just described played out in real time. And if you talk about OCA, you're talking about a very different situation than everything else, right?
I don't think the regenerate data is going to include digital pathology, but it will include a reassessment with 3 pathologists. Poor Intercept, I have no formal relationship to them, but they have been at the point of the spear and taken all the hits for the field time and time again, and yet now they've gone to great lengths to adjudicate all the biopsies and to try to minimize the interobserver variability, all of which in my view could be replaced by digital pathology that measures it once, measures it the same every time, and doesn't rely on keeping pathologists employed.
And Scott, I believe that we all do, but I thought the Shaw paper was a little different, which is if in fact you're still using a discrete yes, no, 0, 1 variable, it doesn't even matter. I mean, I thought one of the points on Q&A was that AI doesn't solve that problem. It solves a lot of problems. It doesn't solve that
one.
Well,
it's a continuous variable, the percent collagen. Somebody made it a point to me that if a biopsy went from, let's say, F3.9 to 3.1, that would be no change.
So now now we're going back to all the discussions about ballooning, right? I mean, this is Quentin Nancy's point on ballooning, which is if ballooning is a discrete variable, you got a problem. But if it's percentage of space taken by ballooning, then in fact, digital pathology can come in and measure it and clean it up, and you become a lot more statistically reliable. At the same time, you become more accurate.
Yeah, Jörn and I actually saw some data in an offline presentation that supported that possibility.
The ballooning is even more imprecise because obviously it's more difficult to grab. I think fibrosis is the most robust marker and readout we can get from liver biopsy. There's inherent sample invariability, and so I'm with Scott saying you can augment that. I mean, to extend the discussion of saying we're discarding drugs, we have to start to consider if we really want to expose patients to a painful, invasive procedure, doesn't carry a high mortality risk, but patients have succumbed to liver biopsy, or at least in the follow-up. Is this still the right test? The discussion is ongoing, and it's beyond this podcast, but it's something to consider. You know, we're generating data to say what we're doing here is a troublesome road.
For what it's worth, as you well know, hepatologists don't like biopsies very much either. And so in the U.S., at least, I don't know about Europe, increasingly they're being sent to radiologists for a variety of reasons.
So in a product theater I happened to catch yesterday because I needed to catch up with both Stephen and Naeem, who were the two people doing the product theater. Stephen talked about how much biopsy he used to have his residents do, and how he just doesn't do that anymore. Fundamentally, it's not anything we need to do. So, Jörn, I think you're right. I mean, this is one of these places where to do the humane thing and to do the scientifically accurate thing are headed in the same direction. Now, how fast we're going to get there is a different question.
Well, it's not the major indicator, but nonetheless, the certification, the licensing board here in the U.S. is no longer requiring liver biopsy as part of gastroenterology training and even liver training. So, the people are voting with their feet whether someone wants to cling to biopsy or not. It's only a matter of a generation. There won't be anyone around who knows how to do it.
And then you got to figure out how quickly you can bring the regulators along with us, right? Because if they lag by 10 years, that's a problem.
Yeah.
So we're kind of at the bottom of the hour. We got started a couple of minutes late. Anybody have anything else that you observed yesterday? Do we want to spend a little time on nomenclature, for example, or is there anything else you saw yesterday that you want to spend some time on?
It's always fascinating. Time moves faster. I had looked at an abstract that was presented by Mazen Noureddin exploring a new therapeutic concept of the mitochondrial uncouplers. Now, that's not totally new, but I think in the field of NASH, it's an interesting one, and it had some robust readouts. So albeit not going into detail with a lack of time here. So this was parallel session 6, UH6 once daily oral compound that is a mitochondrial uncoupler. It has some modifications to avoid a rapid reabsorption and thus has a steady exposition and PK profile. And this is a short 61-day study, double-blinded. Safety and efficacy was assessed over 3 doses in patients overweight, starting in a BMI of 28, going up to 45. So it's not a liver histology-based trial, stratification on A1C to reassemble insulin sensitivity. And the primary endpoint was liver fat change, which I think for this MOA is a valid target. We've discussed earlier that this must not be the sole truth for every therapeutic compound, but here it was explored, and secondary endpoints included, of course, safety, because these compounds can lead increased resting temperature, and that was actually something that came out of the discussion too, probing, do you see safety signals here? And no, the presenter responded this was a fairly safe, very safe in those patients studied, and no increasing base temperature in the patients, which is what happens if you uncouple mitochondria and have to get rid of the energy. So 80 patients were enrolled in those 3 arms. The full analysis said there was a dose-dependent reduction of more than 30% on MRI-PDFF, which is the typically explored endpoint, 30% and more MRI-PDFF reduction. The full analysis data set, 40%, 71%, and 72% in the 3 doses, 150 mg, 300 mg, and 450 mg, respectively. And there was a decrease in A1C, so the authors concluded that using a mitochondrial uncoupler, you can defatten the liver, and it was a fairly short trial, 8 weeks, I believe, and I haven't mentioned that. So you can, using this type of approach, defatten the liver, and I think it adds to the MOAs that we've seen, and that could be potentially interesting in the future.
Yeah, credit to Jerry Schulman, who's been doing the basic biology, establishing the rationale for mitochondrial uncoupler. He gave a very nice talk on Saturday afternoon, establishing some of the underlying biology that justifies the use of these as a potential new therapy. If people want to know more about the basic biology and biochemistry, hopefully you can access his presentation, but it's exciting.
So, Jörn, I'm back in Barcelona listening to Marcus Rani talk about going to a costume party when he was 1 years old as Mito Man, because he decided to describe himself as the all-time mitochondrial nerd. Now, he's going off in a completely different direction with that, but I intend to send him a note on this paper and get his reaction to it, because it strikes me that it's aligned with a lot of what he's discussing that consumers and high-impact athletes and all those people should be looking at for themselves.
Yeah, it's funny you mentioned that. I had thought of him too, and the way he tries to scale it is that he biohacks himself. Now, I think that's a modern word of lifestyle changes, and it could be an additional aspect. Again, if you have a lifestyle change you want to support in the first 4 to 8 weeks with a mitochondrial uncoupler, then take that uncoupler out. I'm not sure you want to be on a coupler for the rest of your life. It's something where you have comes in disease-dependent, stage-dependent treatment, then take it out again and see where you end up.
Well, that is a concept that I think has been raised in different contexts of effectively an induction therapy of one sort or another, followed by a maintenance therapy. So I think, maybe it'll be the uncouplers that are the induction, maybe it'll be other metabolic therapies. Part of the discussion centers around how you give the drug. And so, for example, there are drugs that are going to have to be injected, either sub-Q or even IV. And for drugs like that, long-term compliance is going to be challenging. But if you can get a patient in the right direction and then maintain them with oral therapies, in principle, that would be very appealing.
So, Jörn, let's remember the next time that we have Mazen with us, which will not be at this meeting, we do a 3-minute detour and ask him about HU6, because I would just love to hear his take on it. We are now past the bottom of the hour, and everybody's got stuff to go to, so why don't we kind of wrap it up? Closing question, one thing you're looking forward to today in the meeting?
I'm looking forward to Takebe's state-of-the-art at 10 o'clock this morning. He has been brilliant in both developing and validating organoids as models for NAFLD and NASH, and he's at the University of Cincinnati. He's giving the Hans Popper state-of-the-art, so I'm excited to learn about that.
Well, I can't say other than I'm excited to head over to the late breakers later today, and of course it's my last full day here in Washington. It's been a ride. It's been very interesting to meet up again, talk to Scott in person, sit down and detail this. I mean, this format we're having here, I'd rather be in a room with you guys discussing this. I think it comes down to some technical issues, Roger, where you told us, stay in your hotels. But it was a disappointment, I have to tell you. But here we are. Still, I think content is great. And, I'm just looking forward for my last day here.
Later this morning, I'm going to a talk titled The Evolution of Disease Modeling in NAFLD, so I'm looking forward to those discussions and going to the poster presentations as well, the late breakers. Those will be really exciting and compelling.
I agree on the late breakers, and then there are a couple of posters that I want to see today that I talked about actually in the last couple of weeks that I want to get back and dive into in a little bit of detail. One of the issues we've not touched on today that we certainly did in the run-up is this whole question of frontline screening and how do we make that better? A, how do we get it adopted as a principle, and then B, how do we do better than FIB4? I think there are some posters on that I found really pretty compelling, and I'm hoping to learn more about those at some point today. And then just a sneak peek from completely behind the curtains. Rachel is hosting a lunch today that Jörn and I will both be at. So I will get to see Jörn in person. I saw Rachel in person yesterday, and that should just be fun in the middle of everything else. So with that, we'll be back tomorrow morning, hopefully with Stephen Harrison and Sven Frank, and I'm missing somebody. But that's okay, because today we thought we'd have Naeem, and we didn't. We thought we'd have Chris, and we didn't. Everybody, I hope you enjoy this podcast, and have a great day listening to what in the conference you catch in real time. And we'll see you back here tomorrow morning. We'll be recording at 7 o'clock. Unfortunately, Jörn, again on video. Take care. There will not be a long business section, but there'll be about a 15-second comment from me after these guys go, and everybody have a great day. Scott, thank you so much.
Great to be part of it, always.
Rachel, thank you.
See you guys.
Rachel and Jörn, I'll see you at the ranch.
See you all later. Slava Ukraini, Heroyam Slava. Glory to the Ukraine, glory to heroes. As usual, we will not have a business report during our in-progress coverage of the Liver Meeting 2022. Instead, join us tomorrow morning when Stephen Harrison and a cast of characters is with us to review the late breakers from today, which will have exciting drug studies, and other results from Monday at the Liver Meeting 2022 from AASLD. Until tomorrow, signing off. Stay safe and surf on. Bye-bye.
Until then, as Roger likes to say, stay safe, surf on, and we'll see you tomorrow morning here on Surfing the NASH Tsunami. Tomorrow morning, join Jörn, Roger, and their guests, hepatology researchers and key opinion leaders Dr. Stephen Harrison and Professors Sven Frank and Ian Rowe, and Global Liver Institute Vice President of Health Programs, Jeff McIntyre, as they review some of today's highlights and key presentations from the Liver Meeting 2022, including exciting late breakers, plus a special interview with Inventiva Pharma Chief Medical Officer Michael Corman.